Good evening, good morning, good afternoon to all delegates from different parts of the world. It's a great honor and a pleasure to have you all on this platform this evening to hear from a legend, truly a legend in her field, Dr. Professor Barbara Schmidt from the University of Pennsylvania, USA, and McMaster University. Madam will be speaking on caffeine for apnea of prematurity, the evidence, and beyond. To moderate this very important session, we have none other than two very renowned and the most senior-most neonatologists of the country, Air Vice Marshal Dr. Daljit Singh from Indian Air Force and Dr. K. Sheshagri from Vishakhapatnam. Sirs, it's a great pleasure to have you here today on our platform. And it's a great pleasure to host the 20th webinar of this IAP NeoCon International Webinar Series of Learn from the Legends. And we hope to see all our audience in physical presence for our next upcoming IAP NeoCon. With this, I hand over the platform to our respected moderators.
Thank you, Manjusha. Thank you, Manoj. Thanks, IAP Kerala branch and NNF team NeoCon 2021, IAP NeoCon 2021. And good evening, all. Happy Pongal to you all. And I welcome you all today's Learn from Legends series, 20th series. And today's lecture is on caffeine, apnea of prematurity, evidence and beyond. And caffeine, all we know that it is one of the oldest drugs which we're using in neonatology. It's almost half a century. And now it has become one of the commonest drugs being used in neonatology. So whenever drug being used in neonates, probably two things which we are interested in. One is its effectiveness. Second thing is any side effects. Okay. And apart from effectiveness, the side effect is most important because the growing preterm brain is very sensitive to that of side effects. Let us know all about caffeine by none other than Dr. Schmidt. I request Dr. Daljit Singh, my senior colleague, to introduce Dr. Barbara. Thank you. Over to you, Daljit.
Namaste to all the audience across the globe. It's a pleasure to introduce Professor Barbara Christina Schmidt. You all know about her great work that she has done. I'll try to take her journey right from the beginning when she graduated in medicine from Germany. She did her post-graduation in internal medicine again from Germany, and then she moved to Canada. Somehow she's liked Canada, and initially, after having been at Hospital for Sick Children, Toronto, she moved to McMaster. That was in 1989. And since then, going through various positions at McMaster, she continues to be a professor at McMaster even today. The journey at McMaster, all of you know, is the mecca for neonatal evidence-based medicine. And she's been one of the chief priestesses of neonatal evidence-based medicine at McMaster. If we use her own words, she says, I am a neonatologist and clinical epidemiologist with a strong commitment to clinical research that improves our collective ability to practice evidence-based neonatal medicine. You see, this single sentence sums up Dr. Barbara to us, her commitment and her passion for evidence-based neonatal medicine. And based upon it, whether it was a trial, the international trial on caffeine for apnea of prematurity, or so many other trials which she spearheaded from McMaster, has added greatly to the evidence that we have on various issues, not only apnea of prematurity and methylxanthines, which she will talk to you, and which we think that's the only thing we know about her. No, there's much more to her, about use of indomethacin in preterm babies, about the target such oxygen saturation in preterm babies, and ethics, how to use the ethics in neonatal research. She has done a lot of work on all these issues. Presently, she is also Professor Emeritus at University of Pennsylvania, Philadelphia, where she has been there since 2007. Her awards, her memberships, her experience has been long. But I must tell you some of the honors which she has received. She has received Society for Clinical Trials Project Impact Trial of the Year Award for long-term effects of caffeine therapy for apnea of prematurity. She has been member of the Order of Canada, which was conferred upon her in 2015. She delivered the prestigious William Silverman Lecture of American Academy of Pediatrics in 2017, and Pediatric Academy Society's annual meeting on Lung Club lecture in 2018. She received Douglas K. Richardson Award for Perinatal and Pediatric Healthcare Research Society for Pediatric Research in 2019, and also Virginia Epker Award on section on neonatal perinatal medicine of the American Academy of Pediatrics. I will not like to come further between you and Dr. Barbara Schmidt, for whom you have been waiting eagerly. Over to the organizers to hand it over to Dr. Barbara Schmidt to carry on with her talk on caffeine for apnea of prematurity, evidence and beyond. Thank you.
Thank you, sirs. Madam, it's all yours.
Thank you. And good evening, good afternoon, good morning, wherever you are on this planet at the moment. And I want to begin by thanking you both, Drs. Seshagiri and Air Vice Marshal, for your very kind introduction. Is the sound okay? Can you hear me properly?
Yes, madam. Yes.
Okay. I also want to thank, of course, Dr. Manoj Varanatu for arranging this wonderful webinar and for doing an end run around the pandemic that we all suffer from greatly in every corner of this world. I will share the screen now and hope you can. Are you okay?
Yes.
Okay. So my topic today is caffeine for apnea of prematurity. And I'll begin with a little bit of housekeeping. I have no financial relationships to disclose, but as was already mentioned in the introduction, I was the lead investigator of the Caffeine for Apnea of Prematurity, or CAP trial, and some might perceive this as a conflict of interest. I should also add that in this trial, caffeine was used under investigator-initiated new drug applications. For the trainees among you, and I hope that there are quite a few of you, here are two learning objectives for this presentation. Firstly, to understand the proven benefits of caffeine therapy for apnea of prematurity, and equally importantly, to judge the potential risks of expanding the caffeine dose and the indication beyond the available sound evidence. I could not possibly address every aspect of perinatal caffeine exposure beginning during pregnancy and extending into the neonatal period in this one talk. But by lucky coincidence, I can refer you to this very recent and comprehensive update on evidence-based information as well as interpretation of that evidence. And this is in this December 2020, so really recent issue of Seminars in Fetal and Neonatal Medicine, which is devoted entirely to caffeine. And on the right side of your screen, you can see all the topics and the distinguished authors who contributed those topics. Caffeine for apnea of prematurity has been called a neonatal success story in more than one recent publication. The authors of this particular article some years ago in Neonatology credit the CAP trial for much of this success. I realize there are many among you who are not as old as some of us are, and who did not practice neonatal medicine in the last century. And those of you may be surprised to hear that in those days, in the 1980s and into the 1990s and the early years of this century, the safety of routine caffeine use was far from certain. In fact, concerns about the safety were really the impetus that made us design and then execute this international trial. Why were we concerned about the safety? Very briefly, throughout the 80s and 90s, there was exponentially increasing evidence in the laboratory pointing to potential harm. In multiple species, it was shown that the methylxanthines, of which caffeine is one member of this class, could do harm to the developing brain under certain conditions. And on this screen, you see one of the earliest and most high profile of these experiments. And I'll take you very quickly through it. This particular study was published in a prestigious journal, as you see at the bottom, Science, in 1978. The researchers here studied weanling mice, so very young mice, in pairs of littermates. And one member of each pair was exposed to what would translate into a therapeutic dose of aminophylline for our preterm babies, and the other member of the pair served as a control. Then these animals were subjected to a profound hypoxic, we could say anoxic event by being placed in an atmosphere of pure nitrogen. And you see on the right side that 10 of the 16 control animals survived this ordeal, but all aminophylline pretreated animals died. It's fair to say that in 1978, when this paper was published, it was not yet possible to explain what might have happened here. But we certainly know now for quite some time that caffeine and other methylxanthines are non-specific inhibitors of adenosine receptors, at least at the standard doses of caffeine that we use in our preterm patients. What does that mean? Adenosine is produced in all of our tissues, and that includes the brain. In the brain, adenosine levels rise when energy demand outstrips supply and brain cells are at risk of dying. Such situations that create this imbalance between ATP synthesis and ATP breakdown include hypoxia, ischemia, hypoglycemia, seizures, conditions that unfortunately we do see quite regularly in some of our preterm patients. So we are having here a natural protective mechanism via adenosine, which protects the brain by slowing down metabolism from energy failure and permanent injury. And this is just a snapshot of the whole package of literature that was rapidly accumulating throughout the 1980s and 90s, pointing clearly to the possibility of harm under conditions that we do see in the neonatal ICU. At the other end, there was very little in the way of rigorous evaluation of what was already a fairly common therapy in our preterm infants. Really, all we knew was that from very small and very short-term trials that caffeine and other xanthines reduced the frequency and severity of apnea, and the average duration of follow-up was only 7 days in those trials. So we just knew that they facilitated extubation, that was known, and also within a few days reduced the need for mechanical ventilation, but it was never studied even to the end of the neonatal ICU stay. So this was really the driver for the CAP trial. And in 1998, we formulated the study question, and fast forward about 20 years, and we have in the recent years reported the results of the final follow-up phase at age 11 years. The target sample size for this trial was 2,000 very preterm infants, and this was an international trial. Roughly half of the cohort was enrolled in Canada. There was only actually one US site in the study, and the other half was almost evenly split between Australia and several European countries. This slide, with its old-fashioned blue background, is 22 years old. It shows the original study question in the PCOT format. The P, as you know, stands for population. So our study population were infants at risk of apnea of prematurity with birth weights of 500 to 1,250 grams. The intervention was caffeine, and we used placebo to mask this intervention, but I need to always add at this point that apnea was treated. It was not left untreated. It just wasn't treated with drug therapy. The main outcome, because of our concern about long-term safety, was the composite of death or disability at a corrected age of 18 months. I should go back and stress the point that our hypothesis was that caffeine might increase the risk of death or neurosensory disability, because really we were concerned about safety, as were many others. But thankfully, we were proven wrong. In 2006, we reported the neonatal outcomes in this trial, and you can see that caffeine had several short-term advantages, none of which had been known up to this point because they had never been studied. So we found that caffeine reduced the risk of BPD, bronchopulmonary dysplasia, the risk of severe retinopathy of prematurity, and it also reduced the use of therapies, both drug and surgical therapy, to close a patent ductus arteriosus. But our main goal was to examine the longer-term outcome at 18 months. The composite of death or disability, the results are shown within the red frame. And I think to many people's surprise, including our own, caffeine actually reduced this outcome significantly. You can see in the second line, and I want to really stress this, the remainder of this slide shows you the components that made up the composite main outcome. And I want to really stress that caffeine has, certainly within the CAP trial, absolutely no effect on death. That is often misinterpreted because the composite included death. You can see that the point estimate is virtually on the line of equivalence. So the numbers are virtually identical and have remained identical right up to 5 years. The main effect on this composite came from a reduction in cerebral palsy, and to highlight this, I've pointed your eyes to that outcome with the red arrow. And at 18 months, we also had a marginal benefit with respect to the outcome of cognitive delay. At 5 years, we again had a composite outcome that included the same components that we studied at 18 months, but we added behavioral problems, which are a common consequence of prematurity, and also general health outcome. And you can see very quickly that the observed rates of this composite outcome still favored caffeine, but you can also see, if you go to the bottom of this slide, that this difference was not conventionally statistically significant. This has led quite a few observers to conclude that caffeine was no longer effective at this age. We never agreed with this conclusion, and here's why. We have multiple strands of evidence, and they were in the same paper, in the JAMA paper where we reported the 5-year outcomes, that caffeine retained important benefits on motor outcomes. So the Gross Motor Function Classification System, GMFCS, is an international shorthand to assign the severity of cerebral palsy. There are 5 levels. It's an ordinal scale. and 1 is the mildest form and 5 the most severe. And when we examine this entire ordinal scale, you can see that the distribution with respect to severity of gross motor impairment favors caffeine and with a highly statistically significant difference. Perhaps even more importantly, cerebral palsy is no longer the most important motor adverse outcome after a very preterm birth. That is now developmental coordination disorder, or DCD, which is much more prevalent nowadays in our graduates than cerebral palsy. Developmental coordination disorder won't land the child in the wheelchair, but it is nevertheless disabling. These are the children who are extremely clumsy. They have serious balance problems. They have terrible fine motor coordination. And so it is a really significant motor impairment in its more severe forms. And this is why at 5 years, Lex Doyle, whom you know as one of the world's most foremost follow-up investigators, is a member of our study team, together with some of us, decided to take a look at the database, at the 5-year database, to ask the question, is there any evidence that caffeine reduces this particular motor outcome? Thankfully, we had collected prospectively at 5 years all the information we needed to reliably assign a diagnosis of DCD. We had administered the movement ABC, which is typically the test used to test motor function in these preschool and school children. We had obtained a full-scale IQ in all participants, because in order to have DCD, you have to explicitly have a full-scale IQ within the normal range. So within above 69, in other words. And equally importantly, you have to explicitly not have a diagnosis of cerebral palsy. So there is no overlap. There's not supposed to be any overlap between these two conditions. And here are the results that were subsequently published in Journal of Pediatrics by Lex. The rates basically 15% in placebo and 11% in caffeine, and a statistically significant difference. When the children turned 11 years, we performed our final follow-up phase to reassure clinicians and parents that perhaps there were lasting benefits, as we hope to find, but also to reassure them, hopefully, that there were no newly discovered risks. At 11 years, we had a main outcome that was a composite of academic performance, motor function, and behavior. We chose this outcome on the strong advice of several academic child psychologists who were members of our steering committee in these later stages. And we called this particular composite outcome functional impairment. You see here the rates for this overall outcome of functional impairment at 11 years. It's almost déjà vu in terms of the relationships between the findings in these two groups. 38% observed rate of this outcome in placebo compared to 32% in caffeine. So again, the observed rates still favoring caffeine, but once again, if you look at the bottom of the slide, a p-value that is outside what we usually consider the threshold for statistical significance. But this slide shows you the components, the 3 components: poor academic performance, motor impairment, and abnormal behavior, that made up this composite. And if you first look at the top and bottom lines here, there were broadly similar rates of poor academic performance and disabling behavior. But as shown within the red frame, once again, we have strong evidence that caffeine reduced the motor impairment, which again at 11 years was studied with the movement ABC, in this case, the second edition. Of the 220 children in this 11-year cohort who had a motor impairment, only 50 children, so less than 1/4, actually had a clinical diagnosis of cerebral palsy. So once again, this points to the importance that developmental coordination disorder has assumed among these children. It's a secondary outcome at 11 years because it is a component of the composite, not the composite, the main outcome itself. But we still believe that this is a true benefit of caffeine. And here is why. It's because of the consistency of this finding. We have shown benefits of caffeine on motor outcomes at 3 different ages, at 18 months, at 5 years, and now at 11 years, using different tests and in cohorts of different sizes. So we do believe this is a real effect. With the observed rates of motor impairment in our study, the number needed to treat with neonatal caffeine for apnea of prematurity to prevent one motor impairment 11 years later is 13, with fairly tight confidence intervals of 8 to 42. Now, what might explain this benefit of caffeine on motor outcomes? Alan Jobe, who needs no introduction to any of you, wrote a few years ago, and this is a direct quote, "Caffeine likely is not a direct brain or a lung drug, but rather a drug that decreases adverse effects of interventions to treat apnea." I could not agree more with Alan's statement, and I will show you and try to explain in the next couple of slides why. In 2006, when we reported the neonatal outcomes of the CAP trial, we also reported these data, namely the postmenstrual age at last use of 3 levels of respiratory support in the 2 comparison groups, caffeine and placebo. These 3 levels were what we call here intubation, so being ventilated with an endotracheal tube in place. Secondly, any positive airway pressure, so that now includes what we like to call non-invasive pressure, so chiefly CPAP in those days, and supplemental oxygen. And as you compare these median postmenstrual ages at last use of each of these 3 levels of support, you can see very quickly that on average, caffeine reduced the time on the postmenstrual age at last use on these levels, each of them by about 1 week. And when we published the 18-month data showing the benefit on neurodevelopment, we performed and published in that paper a post-hoc explanatory analysis in which we examined 6 different possible predictors, intermediate outcomes that might explain some of the benefit we saw at 18 months. And we found that the postmenstrual age at last use of any positive airway pressure was the best predictor and explained basically half of the benefit at 18 months, which for a single biologic variable is actually very, very strong predictive power. And because of this finding at 18 months, at 11 years, we did one single post-hoc explanatory analysis. And that is also in the 11-year paper. We simply asked how much of the caffeine benefit on motor impairment at 11 years can be explained by the postmenstrual age, PMA, at the last use of any positive airway pressure in the neonatal ICU. And we, as you can see here, basically got the same result as at 18 months. 53% of that caffeine benefit was explained simply by the postmenstrual age at last use of any positive airway pressure. And the confidence intervals are shown there, 22 to 100%. I should add that although that is often bandied around, and I know some people give caffeine nilly-willy as a brain drug, there is to this day no credible evidence that caffeine has beneficial effect on the preterm brain outside of this mechanism of reducing exposure to noxious other treatments that we have to use for apnea of prematurity. Let's talk about dose, which is one of the hotly debated topics these days when it comes to neonatal caffeine. Here is our regime in the CAP trial, very conventional dose. We're talking about caffeine citrate, I should say, 20 milligrams per kilogram loading. The maintenance dose of 5 is the standard per kilo per day, but we allowed up to 10 milligrams per kilo every 24 hours. I should tell you also, although we have not directly published this, that in the CAP trial, in both groups actually, only 40% of the participants stayed on the equivalent of 5 milligrams per kilo per day. So in other words, 60% were increased by their local clinicians to somewhere between 5 and 10 milligrams per kilo and day. There have been a number of small trials comparing higher doses of caffeine with standard doses. There have also been observational data, and there have been also quite a few systematic reviews and meta-analyses. This particular forest plot comes from a systematic review by the group around Ravi Patel at Emory in Atlanta, published 2 years ago or just over 2 years ago in Clinics in Perinatology. And you see here 3 randomized trials listed in which higher doses of caffeine were compared with so-called standard dose. The outcome of interest here is the risk of BPD, and you can see in the forest plot that higher doses do seem to have a beneficial effect compared to so-called standard on this particular outcome. Unfortunately, however, none of the 3 trials use the same high dose. That's the first problem. The second problem is not even the standard dose was the same in all 3 trials. So the next problem, of course, is that if you look at the numbers, they are still very small. We don't even have a total of 500 children not in this analysis, and the outcome is short term. So my take on this, and I agree with the authors of this particular review, is that I do believe we have insufficient safety data at this point in time to advocate routinely higher doses of caffeine than what we used in the CAP trial. This, of course, does not prevent some opinion leaders from advocating higher doses. I don't know how many of you, depending on where you are, pay attention to the UK NICE guidelines. These are national guidelines, and here is a quote from their NICE guideline published in April 2019 that is called Specialist Neonatal Respiratory Care for Babies Born Preterm, and it does contain obviously a section on caffeine. And I have to tell you, I fell almost off my chair when I read that particular section on caffeine. Here is a direct quote from that guideline. It says, consider a maintenance dose higher than 20 milligrams per kilo daily if therapeutic efficacy is not achieved while ensuring that a safe plasma level is maintained. Well, there are several serious problems with this statement. The first is, what is a safe plasma level? I don't know. I don't think anybody really does. And the authors of the guideline don't tell us what a safe plasma level is. And although I don't have the time to go in any detail into the pharmacology and pharmacodynamics of caffeine, I should stress one important fact. I said earlier that at standard doses, caffeine competitively inhibits adenosine receptors. But at higher doses, the pharmacodynamics of caffeine and other xanthines become much more complex. And as Jacaranda in this chapter that I, in this seminars in fetal and neonatal medicine wrote, they become much more worrisome and of course much less studied. The second serious problem with this NICE guideline is that this. I showed you the 3 trials that have compared higher versus lower doses, and I told you also that none of these 3 trials had the same high dose, but none of them, not one of them, used a daily maintenance dose above 20 milligrams per kilo as recommended in this NICE guideline. So I'm really unable to comprehend how such a non-evidence-based recommendation can make it into a national guideline. In contrast to the very problematic UK NICE guideline, this guidance for clinicians by the Committee on Fetus and Newborn of the American Academy of Pediatrics is much more evidence-based. I don't always agree with the statements that the AAP puts out, but this particular one, which was first authored by Eric Eichenwald, now in Philadelphia, is really very sound. It's about much more than caffeine. It is covering what it says it does, apnea of prematurity. And even though it was published 5 years ago, it's still quite valid today. Here is what the AAP has to say about caffeine. Caffeine citrate is a safe and effective treatment of apnea of prematurity when administered at a 20 milligram per kilogram loading dose and 5 to 10 milligrams per kilogram per day of maintenance. And that, of course, is the regimen that we used in the CAP trial. Another topic that has received a fair bit of attention in recent years is the question of the timing of the initiation of caffeine therapy. How early is early and for whom? Once again, here is a quote from the UK NICE guideline. Use caffeine routinely in preterm babies born at or before 30 weeks. We will get to that shortly. But it says starting it as early as possible and ideally before 3 days of age. Where do the 3 days of age come from? Well, we do think they can be traced back. This 3-day threshold has been used in a lot of publications since. We believe it can be traced back to the CAP trial, and here is why. So in this trial, infants could be randomized between birth and 10 days of age, but the median age at enrollment and therefore at administration of the study drug was 3 days. And not long after we had published the initial main CAP trial papers, Peter Davis from Melbourne, a very close collaborator, and of course somebody all of you know from his wonderful work, especially on delivery room resuscitation and high flow cannulas and so forth. Anyway, Peter published this subgroup analysis paper, which included one subgroup analysis related to timing of the initiation of caffeine therapy. And he simply divided the cohort into 2 time periods, early and late, by the median, so below and above 3 days of age. I think that's where the 3 days everywhere are coming from. So this is a forest plot that was included in that publication. And here we have again post-menstrual age at last positive pressure ventilation, PPV, by age at randomization. And you can see, again, helped by the big red fat arrow, that the effect of being able to wean from any positive airway pressure was far greater in the early than in the late group. And you can see at the bottom that this test for heterogeneity, so the interaction test, was significant, so making this a valid subgroup comparison. There really have not been meaningful, conclusive randomized trials on this topic. There has been one single trial comparing early versus late out of Miami. I'm not even showing you data of this trial because, as I said, unfortunately, I believe it is inconclusive. It was very small to begin with, but then they stopped early, so the total sample size is barely over 80 patients. And what they did was actually something very important, and somebody should repeat it. They randomized babies who, after birth, very preterm babies, who had significant lung injury and were stuck on the ventilator. And we don't know if these fully mechanically ventilated babies, maybe even on high frequency oscillation, whether they should be started on caffeine when you can't really immediately wean them. So that was the question they wanted to ask, a very important question to which we still don't have the answer. And then they randomized them to this early caffeine in fully ventilated babies or placebo, and then they were all switched to open label caffeine when they became ready to wean. And they found no difference on their main outcome, which was earlier extubation. But as I said, there was so many problems and the trial was so small that I don't believe we have any randomized trial evidence on this topic to date. So we are stuck with observational studies, of which there are quite a few, and they've been summarized in this forest plot once again in the same systematic review by Ravi Patel and colleagues. You can see some of these observational data sets are quite large, the one by Dobson using the pediatrics with the next database, but large sample sizes don't help when it comes to bias in observational studies. And so obviously these studies are all prone to serious biases, including survival bias. You can also see in the forest plot, and I should add the outcome again is risk of BPD. You can see in the forest plot that these data are very heterogeneous. There's a lot of inconsistency. You can see the I-square as high as 97%. So you judge for yourself if you should even believe these data. Here is my take on when to start caffeine. I believe it is actually a completely wrong question to ask this question and expect one single answer, because I think it depends on basically two parameters. What is the gestational age of your patient, and what is his or her respiratory status? What do I mean by that? If you have a baby who is, and I don't really want to argue about whether you take the cut point at 29 weeks or 28 weeks, or maybe even at 30 weeks. Basically, if you have a baby who is in that vicinity, and so not extremely preterm, but more moderately preterm, I would suggest wait until apnea develops. Don't give it prophylactically. Why? Because these moderately preterm babies do not universally develop apnea. Most do, many do, but not all of them. And we should never forget that the evidence that made us do the CAP trial in the first place about possible harm has not gone away. It's just that what we believe happened in the CAP trial is that this potential harm was completely offset by the benefit of getting these babies off other noxious therapies for apnea of prematurity. So I would advocate in the more moderately preterm babies that you wait until apnea develops and don't give it prophylactically. We talked briefly already about the special situation where an extremely preterm baby is fully ventilated. I would say at this point in time, start caffeine as you're beginning to wean, because more rigorous trials are needed before earlier initiation of caffeine in those infants can be justified. Thankfully, we don't see that many babies in this category anymore, but they do still exist. And I would suggest wait till you're ready to wean. Everybody else, so extremely preterm babies with little or no respiratory support, yes, please start caffeine early. That's what we did in the CAP trial. We have to remember that half of the entire cohort was enrolled before 3 days of life. We did probably in those days, it was 1999 to 2004. I doubt that babies were enrolled in the delivery room, so that's a special situation and some people are studying it. But certainly there is every reason to believe that those very immature babies who are inevitably going to have irregular breathing and apnea will benefit from caffeine. Before I close, I want to stress my concerns these days, and that is that I'm really worried about treatment creep. And so I think you've seen that right through the entire presentation. I can't stress enough, the indication is apnea of prematurity. Don't give it as a brain drug just because the baby is preterm but doesn't actually have a serious apnea problem. We talked about doses, and I do believe that we should not exceed the doses for which we have the safety data that everybody is so happy about from the CAP trial. The timing we just reviewed in this last slide, I suggest should be guided by the gestational age, the degree of immaturity of the patient, and the respiratory status at that point in time. And the special case of the baby who's fully ventilated from the delivery room onwards for days to come, I think merits further studies. I have not in this talk talked about when to stop. I'm sure when to stop the treatment, I'm sure that will come up in the questions. So at this point in time, all I can do is thank you very much for your attention. And I also want to end with a big thank you to the 2006 CAP children and their families, our trials group at McMaster University, and all of our collaborators around the globe, and our funding agencies, chiefly the Canadian Institutes of Health Research, who funded most of this trial, including all of the various follow-up phases. Thank you.
Thank you very much, madam. You have told us how caffeine made the difference to the preterm babies who had apnea of prematurity, and how all the issues related to safety were answered. How, when you went along down the time lane, you showed us how they were followed up on long-term basis at 18 months, at 5 years, 11 years, and you established the safety of caffeine in these babies. A very important thing that you told us was about post-menstrual age. The post-menstrual age at which these babies received last positive airway pressure was very relevant in looking at long-term outcomes. That was very, very important, ma'am. Ma'am, the question which people have essentially asked, they again have rotated around higher doses of caffeine, which have answered in very, very clear terms that higher doses, we still need the safety data. We cannot go on high maintenance doses beyond 10 milligram per kg. They beautifully brought out in the studies on BPD effect is still not very clear. Numbers are very less. The timing of initiation of caffeine therapy, ma'am, there are again a number of questions which I will put to you at this stage itself. People are saying, you talked of ventilated babies, you talk of minimal support, Do you also mean CPAP is equivalent to minimal support, ma'am, when you talk of?
Yes, I do.
Okay, fine, ma'am. And the early, they're saying, is day one also included as early if the therapy started on day one, madam?
So the half the cohort was enrolled at a median before a median age of 3 days, and there is a little bit confusion. To be honest, I don't know how you count the days in India, but I know that a lot of my American colleagues, because I practiced neonatology in the States for 10 years in Philadelphia, I know that they get confused because as to how many days that actually is, because they have the habit of calling the day of birth day 0. So for them, day 3 is then actually already basically up to 4 days, which is not how we did it in the CAP trial. We didn't have a day 0. The day of birth was day 1. So the median age was truly, and obviously the day of birth can be half an hour if the baby was just born before midnight. What I do suspect, because, it just wasn't so popular in those days to try and keep these very immature babies on CPAP right from the delivery room. So, and of course, enrolling in a trial in the delivery room of this complexity is also not something that is easily done. So I suspect there were no enrolled. We have never actually checked this because we didn't even collect that information in terms of hours. But I suspect that there were no enrollments in the delivery room, but certainly within a few hours of birth.
So we could start on day 0, day 1, as we call it, or within few hours of birth, we could start caffeine when we call it early caffeine, ma'am. Is that the take?
Yeah, and I have been, when I was still, I'm not any longer doing clinical medicine. I've retired from that a few years ago. But when I was still involved in that, I was recommending, certainly right on admission to the neonatal ICU, if a baby was in that, like a 27-weeker on CPAP, universally almost bound to have apnea. And yes, why would you want to risk CPAP failure in a baby like that?
Ma'am, as we mentioned, the number of questions on how long to continue caffeine. And they talk in terms of gestational age, post-menstrual age, time since last apneic episode has happened. We'll request you to dwell on it briefly.
Right. It's a very important question, and the answer to it is, again, a little complex. The really honest short answer is that we don't know for sure, that there is further research that needs to be done, and there are actually trials underway to address this question. But one thing I'm certain about, it is not a single number. It's not going to be one post-menstrual age at which everybody can be discontinued. Why? Because we know already that the more immature a baby is, so the lower the gestational age, the longer on average it will take this baby to resolve apnea of prematurity. We also know that some babies have problems right up to term, and the CHIME study 20 years ago showed us that that is still definitely within the realm of apnea of prematurity. So in the CAP trial, we did not prescribe when to stop, but we made recommendations. And one of the recommendations was that positive pressure for treatment of apnea should have been discontinued first before discontinuing the drug. But again, as I said, I don't know why some people are so anxious to stop so early. A baby who was 23 weeks is totally entitled to still have apnea at 36 or 37 or even 38 weeks post-menstrual age. And as I said, there are at least 2 trials I'm aware of that are trying to address this question with a little bit more detail. We also know, and from Ryan's studies in the US, that there may be a reason to go for longer because of these not often very noticeable hypoxic ischemic events that some of these babies still experience when we think they are out of the woods. But those are still all open questions. But at this point in time, I think it should be individualized, depending on how immature the baby was and how much of a problem apnea still is.
Yes, ma'am. So as of now, no general statement to be made. But if the baby is having apnea, naturally you have to continue caffeine and wait for 5 to 7 days after that, however long we might have to go on. Could we say that kind of statement, ma'am?
I think so, yeah. I think it's safe to wait a week.
Yeah.
5 to 7 days minimum, yeah.
Okay. Dr. Seshagiri? You are mute. Dr. Seshagiri, you are mute. Dr. Seshagiri, you are mute. Unmute yourself.
Yes. So most of the questions are answered, sir. One more question I found interesting. Does it have any role in the HIE babies who had some hypoxia, ischemia, and also role of caffeine in term babies for having apnea?
Let's start with the second part. Babies who were ex-preterm babies now at term, or babies who were born at term? Which is the question?
Term babies, madam, not the preterm babies, the born term. They're talking of gestationally born term, ma'am. Beyond 36 days completed.
I don't see any reason to ever consider caffeine in a term baby. I wouldn't know for what indication.
In preterm babies who are having mild asphyxia-related problems, does it help?
Who are having what?
HIE related.
HIE, okay. Yeah, and do you think they have apnea because of that, or?
No, ma'am. They are saying methylxanthines have a protective effect on brain in HIE. So, do you advocate in
does it have any role?
I don't know. It hasn't been properly studied. That is not an indication that I would consider established. I mean, if the baby also has apnea of prematurity, it's obviously indicated. But I really do not think there is any data that is credible or consistent to show that caffeine has a direct effect on the brain. Even the laboratory studies are inconclusive. And, you know, Lex Doyle's group in Melbourne published a paper some years ago showing MRI benefits in the caffeine group that at the time they said was not explained by a reduced rate of BPD, which in itself obviously is not good for your brain. And that paper has been quoted a lot and received a lot of attention. But what has received much less attention is a follow-up paper from the same group in Melbourne, published, I think, 2 years ago, when the children were older, and they repeated the MRI study and could not find any difference.
So there is one more question related to what is the role of routine monitoring of the levels of caffeine?
I don't think there is any in routine care. I mean, obviously, if you go to ultra high doses, you can measure it. But then again, what are you accepting as too high? It gets problematic very quickly. In the CAP trial, we did not do in over 2,000 infants a single level. And we actually prohibited levels because they would be unmasking. If somebody, and we made it very clear that if you think a baby has toxic symptoms like tachycardia, tachypnea, that sort of thing, the only real measure is there's no antidote. So there's therefore no reason to have a level. The only right answer, regardless of a level, is to hold the caffeine until the symptoms subside. Yes, they are non-specific, but the level wouldn't actually help you do anything different.
One more question related to again caffeine. Can we discharge the babies home on caffeine?
Before I get to the home, I just want to be, just so I'm not misunderstood. So for caffeine, I don't see any need to do levels in routine care. for research, it's something different, but not in routine care. But that is very different if you're using aminophylline theophylline, because the therapeutic margin here is much narrower. And so you absolutely, if you use aminophylline theophylline, you have to do levels, just so we don't get the two mixed up. Home caffeine. So that is actually one of the studies in the US in the Neonatal Research Network that is looking at that. At this point in time, I know some people do it. I have never sent a child home on caffeine in my own practice. I think it needs further study, and those studies apparently are being done right now. So hopefully we can answer that a little bit better.
Ma'am,
coming years.
the side effects, people are still asking a lot of questions, hyperglycemia, other side effects. What would you want to tell them about the safety of caffeine?
Yeah, so we did not, yes, I mean, those are typically toxic effects, short-term toxicity. So we did not routinely measure any biochemistry or stuff like that in these babies. We wanted to do a manageable, in 9 countries and large sample sizes. So we wanted to do a manageable trial. We did not want to get lost in blood samples that also might make it less palatable for the parents to be involved. So I think these are known in the literature as signs of toxicity. We did observe in the neonatal period less weight gain in the first months of life in the caffeine-treated babies. And that is no surprise, because caffeine is a powerful drug in many ways, and it does increase the metabolic rate. But those differences were evened out within 3 to 4 weeks and never showed up again at follow-up.
Okay, ma'am. Okay.
There are few,
yeah, Dr. Shishak.
yeah, there are a few questions related to, again, feed intolerance and NEC in the caffeine complications, what we have discussed, hyperglycemia. But what about feeding and feeding intolerance, whether we should alter the dose or we should stop, or is there any relation to NEC? There are a few questions regarding that matter.
Yeah, there is the NEC question. I think I can answer quite confidently. I know it's still in the US label, in the FDA label, that it may increase NEC based on very shaky data from a very small licensing trial back in the 1990s. In the CAP trial, we had no hint of an evidence that caffeine increased the risk of NEC. In fact, the rates were basically the same, down to a decimal point almost.
Thank you, ma'am. There are few questions on oral versus IV. Oral doses versus IV doses, maintenance, whether 12 hourly or 24 hourly, and use of mini boluses. Would you like to address this?
So are these 3 different questions, right? So oral versus, so the beauty of enteral caffeine is that it is very quickly available to the body, and fully 100%. So the dose is exactly the same because it is fully available to the body as if you were giving IV. That's an important, in fact, in many situations, the enteral formulation is, well, it's exactly the same as the IV, and you can actually give the IV formulation enterally. So that's all very good. And I think for those who have maybe, for parts of the world where it is not so easy to maintain IVs, that is an important piece of news. The other question was now.
12 hourly or 24 hourly maintenance dose.
Yeah, so this is an interesting question. So in the first few weeks of life, there is no question that once a day is more than adequate, simply because we know the pharmacokinetics have actually, in the first few weeks after birth, very well studied. The half-life is so long that it makes no sense to divide the dose into two. It just increases your nurses and pharmacies' workload. As the child matures, and particularly if we're beginning to think to give it perhaps longer than we used to, we have to remember that as the child matures, the half-life of caffeine reduces. So while I can say that in the first months of life, there's basically never a reason to give it more than once a day, I cannot say this as confidently as the child gets older and more mature. And if you go to this issue, and I have to say, I have no personal benefits from from advertising this issue in seminars in fetal and neonatal medicine. But I did choose the authors and the topics, and there is a beautiful chapter in there, again by Ravi Patel and a colleague, about standard dose, high dose, or dose adjusted for age. And they quote a very interesting paper that you may also be familiar with, where people have actually provided a formula based on pharmacokinetics over time, how you may want to increase the dose just simply with advancing postmenstrual age in order to counteract this change in the half-life and bioavailability of caffeine.
People talked asking about, ma'am, the mini boluses. A baby while on caffeine develops apnea. Do we give another mini bolus to the baby, let's say 10 milligram per kilo to that baby, and that kind of questions?
Yeah, I mean, that's another way of sneaking in higher doses through the back door, right? it's yeah, you can do that once if you have any doubt that maybe the previous dose was, if you gave it enterally, that it may have been regurgitated, or if you think your IV went interstitial or something. If you have any doubt that your caffeine that you've given so far actually arrived, perfectly legitimate, right? But if you keep doing it, you're just going to go and basically use higher doses.
Okay. Ma'am, if we get little away from CAP trial and from caffeine, you have been in the field of neonatal evidence-based medicine for such a huge period, so many years. So would you like to tell all the audience here some issues, some points about how to conduct research ethically in newborn babies when we're talking of conducting the randomized controlled trials and studies which are going to be relevant and useful to these small preemies?
Oh my God, I could talk for 3 hours about that topic. I think I want to maybe rephrase it and point to something that continues to worry me. You see, my generation came after the generation that Bill Silverman described, who's long passed, but the ones that created the retinopathy of prematurity epidemic by giving oxygen indiscriminately in the 1940s and 50s. So we came after them. We made a lot of mistakes, and with our work, we've tried to address a tiny bit of that. As a neonatologist who's practiced since the early 1980s, I am disturbed that we still haven't figured out what to do with the patent ductus arteriosus. I think that's a scandal. And that we still don't know which ducts matter and which don't. Clearly some matter and some don't, but nobody has figured out in real time how we can identify the right baby. I think that is disheartening. I'm also disheartened by every generation seems to be having to repeat the mistakes that the previous generation made. What I mean by that is I'm hearing from my junior colleagues that I don't know what it's like in India or wherever you may be practicing, but I certainly know that in North America, all of a sudden, acetaminophen, paracetamol, has arrived in the neonatal ICUs and is being handed out, almost indiscriminately. And I think that's extraordinary, because when you actually look at the clinical data that we have about such a powerful drug, again, all we know from very small and very, very short-term and limited trials is that it closes the PDA, but what else it might do to the baby is anybody's guess. And yet people, make the same mistakes that they have made so many times. So I keep hoping that something will change and that people ask the right questions and do the right studies before these things just suddenly go into the mainstream. Look at the disaster we created by trying to be gentle and kind when suddenly in the 1990s everybody was put on morphine, right? It also came from nowhere, just because we thought we were kind to these babies, but we did more harm than good.
Thank you, ma'am. Thank you. Thank you very much. Dr. Shagri, you would like
I
to...
think all questions are covered, sir. And last question is very valid question, which is apt to the present situation. Thank you, madam. And we'll hand over to Dr. Manoj and his team.
Thank you, Dr. Manoj. Thank you, madam. It's been a pleasure interacting with you.
Thank you very much. Thank you.
Well, it was such an excellent session. Before we close the session, may I request another legend who the legend who started it all, Professor Ola Sockstead, who is fortunately here with us today, who inaugurated our webinar series with the first talk, to give his remarks before we close the session. Professor Ola, sir.
Thank you very much, Dr. Manu. It's hi, Barbara.
Hi, Ola.
I would like to congratulate NF in Kerala for this marvelous series of lectures. I haven't attended all of them, but some of them, and I looked at the speakers, and it's just incredible. And I think Barbara Schmidt's lecture today proved that. Barbara, this was a fantastic lecture. I really enjoyed listening to you. So I would like to congratulate you, Dr. Manu, and all your colleagues. And I hope to see you in person in Kerala or somewhere else very soon.
We do hope to see you both, madam and sir, when we plan to host the physical conference, hopefully this year, towards the end of this year in September. That's the plan.
Yeah, and I look forward to see you, Barbara.
Yes, me too, to see you. Stay safe in the meantime, Ola.
Yeah, you too. Thank you. Thank you so much.
So, thank you, Professor Ola. Thank you, Professor Barbara. Thank you, the moderators. Madam, it was such a nice session, and it was truly nice of you to spare so much time for us. So, we come to the end of this session. Let me thank all the delegates who have been with us, to more than 300, around 300 delegates from 65 countries now with us, who are viewing this, and the YouTube channel who continue to view in the next few days. The next few sessions in February are going to be on neonatal hemodynamics, and except for one session by Professor Daniel De Luca in February, all the other sessions in February and March are going to be on neonatal hemodynamics. We begin the hemodynamics series on 30th of January with a session by Professor Subair Agai on umbilical cord management of non-vigorous neonates, the updates and future. So I welcome you all for that. Thank you today for joining, all of you. Have a good day. Thank you.
Thank you. Bye-bye.
Thank you, madam. Thank you.